To talk to you today about intraoperative OCT. I don't have any financial disclosures. Thanas will say, unfortunately, he would like me to say that, but anyway. So, you are all aware of all the evolution and all the advancements in ophthalmology over the last years. Phaco in the 60s, pars plana vitrectomy in the 70s, surgical microscope, we're using the foot pedal, hands-free manipulation, wide-angle systems that helped us a lot to do a better and safer surgery. And as far as the surgery, the surgical machine is concerned, the flow control, which is very important, the high cut rates, and the small incision surgery. And you're all aware also of the OCT. You use it every day in your practice. We use it for the anterior segment. We use it for the retina. We use it for the optic disc. What about surgery? We haven't used it so far for surgery. It would be useful to use it for surgery because, for example, you could have immediate feedback during surgery of what you're doing on the retina. You could be aware of new anatomic configurations that are happening during surgery. Or you could change or improve your surgical manipulations if you were able to use it during surgery. But why hasn't been used for surgery, the OCT? Because there was so far a lack of integrative solutions. There was a lack of portability. You know, you have the machine, you have the clinic, the patient has to put his chin on the chin rest, and you have to go and do the OCT. It's a big machine, you can move it around. It was very expensive. It will disrupt heavily the surgical flow of your cases. You needed specialized software, and also we didn't know if it was clinical, if it was clinical useful, if it was good for our patients. But slowly, some people started thinking that it might be useful to have it done during surgery. So they thought about how they could do it. You could do a modification of the tabletop system that you had already. Or you could create new portable systems, like the handheld OCT, external mount externally the OCT to the microscope, or to have the integrated to the microscope solutions. First, it was tried the handheld system because by using the tabletop machine, it was very difficult to carry the OCT from the clinic to theater and do the scan. So they tried to do a handheld OCT, and of course, the first cases that it was tried on was pediatric ophthalmology because that's where it was more useful. It's more difficult to examine the kids. And the main disease was retinopathy prematurity. So Cynthia Toth and others started using the portable, the handheld OCT. But it had many shortcomings. The main ones were that it was impossible to do two scans at the same place, almost impossible. There was a delay in the scan, and there was a lack of stability because it was handheld. You couldn't hold it stable and scan the retina. So you had low quality, you had a lot of artifacts, you couldn't find the target very easily. So there was a problem of quality on doing the OCT in theater with the hand. And also you had to desterilize your surgical field. So you had your surgical field nicely done, you had to desterilize and sterilize it again. So that would disrupt heavily your surgical flow. So really, that was out of the question. So the next thing that they did was to externally mount the OCT on the microscope. So you got a bigger microscope with an externally mounted OCT machine. It was controlled by the foot pedal. You could see it on a monitor, but what the surgeon had to do was stop the procedure, move the microscope away, put the OCT, do the scan, and then put the microscope again and carry on the procedure. That also would be very disruptive to the surgical flow. And so we came to the integrated solution that we have today, which means that the OCT is integrated into the microscope. So it's one thing, microscope and OCT. It was mounted on the Leica and the Zeiss microscopes. On the Zeiss microscope, we had the Visante OCT for the anterior segment, because if you remember, we have an anterior segment in the eye too, and the Cyrus was used for the posterior segment. It's the first time that we had real-time OCT, so the surgeon could have OCT on the same time as he was operating. It was the first time that you could see the tissue interaction with the instruments and with the surgeon, but we started having some new issues. We started needing new software because it was a real-time OCT. We needed new instruments, and you see later on why we need new instruments. You need a new visualization as a surgeon because you were the surgeon, you were doing things in the eye. And there was the problem of the Z-axis stabilization. What is the Z-axis? As you know, when you do the OCT in the clinic, you put the patient on the chin rest the patient is stable, and then you have to go, focus on the retina, and then start doing the scanning. That movement from where you are to the retina, that's the z-axis. That's when you do the OCT in the clinic, is stable. But in theater, that's changing all the time. The eye is moving, you are moving, your instruments are moving, so the z-axis is moving all the time. You need a way for the OCT to focus always where your instruments are. So that means that you have to eliminate the z-axis. And also, you need auto-tracking, something that our anterior colleagues have it for many years now. You need to be able to focus where you're working, where your instruments are. And you need to be able to focus to other areas. For example, you are removing a membrane on the fovea, but you want to know what's happening outside the arcade. So you need to be able to move the OCT outside the arcade and see what's happening there, whether you're pulling or you're creating a hole. So far we have 3 commercially available solutions that are integrated OCT. One is the Zeiss Riscan 700. This is based on the Zeiss Lumera 700. It's using the Callisto external video system. It's using a touch system, and has video and OCT combined in one picture. It has a control through the foot pedal, and the surgeon can, from the machine, change the target, change the orientation, and change the size of the OCT scan. On the screen, you can see the surgical field and the OCT, and you can see it here on the right-hand piece. The right eyepiece shows you the surgery plus the OCT, and the left one shows only the surgery. You can see a picture there. It's good, very good to use for anterior and for posterior segment cases, and eliminates the problem with the z-axis, as I told you before. The next one is the Hackstride. Hackstride should have one as well. So it's the Hackstride IOCT. This is based on the OpMed OCT. It has 2 monitors. One you see it up there. That's a touch screen. And one you see the bigger one there, which shows a big picture of the surgical field and of the OCT. It's using near-infrared optics. It's using the microscope focus and zoom. And the OCT unit is the one that you see here, on the base of the microscope. It's using 10,000 scans per second and has an X-ray resolution of 7.5 to 10 microns and lateral resolution of 10 microns. So it's not the fastest OCT we have around, but it does the job very well for surgery. Then we have a company, the Bioptigen, which created an OCT for both the Leica and the Zeiss microscopes. For the Leica is calling it N-Focus, has a very low resolution of less than 4 microns, and has a depth of 2.5 to 11 millimeters. And it's so deep because it's using the swept source OCT. That's why it's so fast and so deep. It can use also for anterior and for the posterior segment. You can have dynamic control through the foot pedal, and also this one has also an external monitor where you have the surgical field plus the OCT pictures. So as you can imagine, once surgeons have started using those, then there were a lot of papers coming out. The 2 main ones of them were the Pioneer and the Discover studies, with 750 patients in total. And they were looking into the use of the intraoperative sleeve in both anterior and posterior segment cases. 60% of those papers are about anterior segment cases, so I'll have to talk about those as well. The indications for anterior segment surgery were mainly keratoplasty, lamellar or penetrating, was cataract, corneal inlays, and glaucoma. In the anterior segment, the 60% of those cases were about lamellar keratoplasty, and from the 2 studies I mentioned before, there were 366 patients. The main procedures were the DSEC and MEC. With the OCT, the doctor saw that you were able to check the orientation, the position, and the way that the graft is unfolding, and whether there is any remaining interface fluid. As you know, if you have a lot of remaining fluid at the interface with the cornea, then you have a poor prognosis and not a clear graft. So with the OCT, they were able to check how fluid there was, and they found that in 18% of cases, when the doctor thought that there was fluid there, the OCT showed that there was no residual fluid. And in 50% of cases, so 1 in 2, the OCT showed that the situation was different from what the surgeon thought. So in 1 in 2 cases, the surgeon had to do additional maneuvers in theater to improve his surgery. So the OCT was quite helpful in half of the cases. And also they saw something else different, which was very, very good. It was that the intraoperative OCT was very useful as a training tool. It was very useful to train young surgeons to start doing the procedure because they could see with the OCT where the flap was. And also it was very good for surgeons who want to go from DSEC to DMEC, also to do the transition much easier by using the OCT. In cases of DALK procedure, the OCT helped a lot the surgeon to know exactly the depth where he or she is in the cornea. So in 50% 1 and 2 cases, the OCT showed that the surgeon was maybe too superficial or too deep into the cornea, and if the surgeon carries on, then he could penetrate the cornea and then turn the procedure into penetrating keratoplasty, so they had to adjust the depth. And also, in quite a few cases, the OCT showed the existence of subclinical big bubble formation. In cataract, you are all aware of the use of the femtosecond lens that is using OCT to get to the eye. Also, with the intraoperative OCT, you can check the intraocular lens position and the corneal incision, and also is an excellent tool to calculate the power of the IOL intraoperatively, which, as you know, is the best calculation. And is doing that based on the exact IOL position and the exact measurement of the anterior chamber depth. So it's very useful for that if you want to do it intraoperatively. But as posterior segment surgeons, we're interested in the posterior segment, and those are the cases that the intraoperative OCT was used so far for optic dyspeed, for retinopathy prematurity, macular holes or epiretinal membranes, for retinal detachments, diabetic retinopathy, and also some cases of posterior uveitis. In children with retinopathy prematurity, the doctors who were doing the surgery and were using the intraoperative OCT were able to use the existence of pre-retinal structures and the existence of retinoschisis, which was very useful during surgery. In cases where they had the optic dyspeed, some surgeons found out that there was a relation between the macular schisis and the vitreous gravity. There was a communication, and that was done with the intraoperative OCT, showing it as the fluid and the retina was moving intraoperatively. Now, macular holes has been quite useful also because the surgeons saw that as they were peeling the membranes or the ILM off, then they saw immediately an expansion of the ellipsoid zones on the RPE. And you can tell that if you see that, and if you see the hole closing during surgery, maybe you could tell your patient that he doesn't need posturing afterwards. But if you do that during surgery, after your removal traction, the hole is still open, maybe you could advise your patient to posture a few days afterwards. So you see you can get individualized care of your patient with intraoperative OCT. Epiretinal membranes were the cases where most of the... okay, I can't reach that. Okay. Epiretinal membranes were the cases where most of the cases the intraoperative OCT was used, and they found a disagreement between the surgeon and the OCT, which means that in 20% of cases where the surgeon thought that had removed all the membrane, like you see in the top slide here, in the top picture here, the OCT showed that there was some remaining membrane on the retina. And in 30%, where the surgeon thought that he had not removed all the membrane, then the OCT showed that there were no membranes left on the retina. Or in cases where you have, you can see easily that you have removed all the vitreous from the retina, as in the picture down. Also, the intraoperative OCT showed macro and micro architectural changes, and also showed that as you peel off the membrane, then immediately you see the expansion in height of the complex ellipsoid zone and RP. You see it during surgery, and that's good for the prognosis of those cases. It has also been used in retinal detachment. It has been used so that with OCT you can see whether there is any residual fluid on the fovea, which is very important. Sometimes we can see it even with macular-on detachments, trickling the fluid under the fovea. And also, even more important, the intraoperative OCT can see whether there were any additional architectural changes on the fovea. Like, for example, it showed that in a few cases you had the creation of occult macular holes during surgery. With all the manipulation we do to the retina during surgery, sometimes you get occult macular holes that the OCT showed, and that could be why some cases after a successful retinal detachment operation they don't see very well. That's because maybe they developed an occult full thickness macular hole. In the DISCOVER study, 20% of the cases, the OCT provide valuable information either for the identification of optimal drainage site, or in some cases, to differentiate between subretinal fluid and white without pressure, whether the area was white without pressure or subretinal fluid. In diabetic retinopathy, I remember that Dan Gregory Murphy was talking for decades how, when you want to do a delamination, you need to find the right surgical plane. You go under the membrane, and then you start cutting and delaminating. If you don't find the right surgical plane, then you are very prone to create holes on the retina, and then you get a retinal detachment. That was very important, and you had to do it in theory. Well, now you have a tool that can show you that. With intraoperative OCT, you can find the right plane, and then you start doing your delamination much more safely. Or imagine you have a patient with a vitreous hemorrhage. That's very simple for a vitreoretinal surgeon. You have vitreous hemorrhage, you do the surgery, you clear the vitreous cavity, you clear the vitreous, and you have a reasonably good fundus at the back. You close the eye, you see the patient in a week, next day in a week, and you see that there is epiretinal membrane on the fovea, and the patient doesn't get good vision. If you had intraoperative OCT, you could check the fovea right in theater and see, is there any edema on the fovea? Is there any subretinal fluid? Is there any epiretinal membrane? And you can deal with them at the spot. Either you peel off the epiretinal membrane, or if you need, you do some anti-VEGF injection at the end of surgery. So in a week, the patient sees much better. So that's what I'm talking about, individualized care during surgery with intraoperative OCT. So that's what's happening today. What will be happening in the future? In the future, we'll see more use of the swept source OCT and of high-speed OCT for intraoperative OCT. We expect to have optimized optics, improvement in digital technology, and improvement in the interaction between the surgeon and the OCT and the ocular tissues. We expect to have to solve the problem with the instruments. As you can see here, when you use the instruments, then it's cutting the picture, but the metal is causing light scattering and shadowing, which means that it scatters the light and you can't see the instruments in the OCT, but also creates a shadow and you can't see the retina below the instrument, and that's a problem. So we need to solve that, and that will be solved either with new novel material or with software processing, which can go around your instrument and replace all the tissues with special software and show the instruments and also show the retina under your instrument. Or you could, we need to use auto tracking. Our anterior segment surgeons have auto tracking now for many years. So you need auto tracking. Why? Because we need to focus where our instruments are. Our instruments are moving, so we need to be focused where our instruments are. We need to focus on different areas of the retina. We don't need to be always on instrument. We need to see other areas of the retina and how they behave through OCT. Or we could even inject some dyes on in the eye to stain, for example, the ILM, and that may enhance the OCT view of those membranes, and then it will be much easier to peel them off. And we need new software, new automated algorithms that will analyze any subtle tissue perturbation. For example, in DISAEC, we could, with the OCT, create the map of the fluid, the interface fluid. And with that map, you can tell, for example, if you have below a certain amount of fluid, then you are safe to leave it because your operation will do well. But if you have above a certain amount of fluid, then you have to reposition your graft because otherwise your operation will fail. Or in macular hole surgery, you can have automated analysis of the whole geometry and the outer retinal changes. You can have like a 3D structure, and then you can predict the closure rate. You can, as I said before, say whether your patient is going to posture or not. If the hole is closing during surgery, then you don't need to posture the patient. If the hole doesn't, then you need to posture the patient. And you can tell your patient after theater, you can tell him that, we did well, and I expect you to get good vision. Or sometimes, we did well, but your eye didn't behave that well. Maybe your vision won't be as great as you would like to do. So that is a way of treating your patients more in an individualized manner and to know exactly what to say to your patient. And also, we are expecting to have real-time 3D images with a head-up display during surgery. For example, 2 years ago, we saw Eckhart in Germany that he was doing real-time surgery without the eyepieces. He was only looking with the 3D glasses at the screen. He did the entire surgery like that. And also we could integrate also new therapies that require very, very precise positioning or dosing of your drugs. For example, imagine gene therapy. You want to have your vector and the gene positioned at the exact layer of the retina. How can you be sure that you delivered the drug exactly at the layer that you want? With OCT. With the OCT, when you see the tip of your needle, you see exactly where you are in the retina, and then you can inject your gene exactly where you want it. Or the same with stem cell therapy and with artificial vision. You want to put your prosthesis exactly on the retina, or maybe inside the retina in the specific layer. That you could do also with the intraoperative OCT. And also you can imagine, as you see here with augmented reality, that's a way to seeing the tip of your instrument and also to see exactly how close you are to the retina and when you grab your tissue. So imagine, for example, the near future that we do a surgery like Eckhart did. We do it all through the computer screen. We can see the surgery from the computer screen. Imagine that you don't like what you see and you don't like the contrast. Then with software, you can change the contrast from color to black and white like we do in the Heidelberg OCT, for example. So some tissues show much better than other tissues. Or, for example, you don't see the eye line very well. You don't need to use dye. What you do is we use the OCT with pseudo-colors. We'll color the eye line green. We'll color the rest of the retina red, so you can see the eye line where it is without dye. You can peel it off with your instruments, and you won't have the use of dye. So you can imagine that it is a very exciting time for surgeons, but all that we have to put it into clinical practice and see how valuable it will be for our patients. Thank you very much for your attention.
First of all, I would like to congratulate you, and I'm really happy you're with us. It was the best OCT surgical steel presentation I haven't seen worldwide. I've been to ISRS meeting, I've been to European meetings, I've been to meetings and meetings and meetings. Everybody's talking about surgical OCT, but everything about surgical OCT in half an hour, no one has. So I'm sure we're going to use your projection and your videos to the whole people, and I'm sure everybody's going to touch screen for that. So I've tested the surgical OCT because we already have the hacks right, but the microscope now, I'm going to logistics. If you want to buy a surgical OCT now, you need to have a microscope that already is coated for surgical OCT. So we bought the microscope, but it's coated for surgical OCT. It costs $15,000 more, and we didn't buy the surgical OCT. But if you want to buy a surgical OCT now, you need to buy a new microscope and a new OCT. This is the biggest barrier in the evolution of OCT, that you have to buy a new microscope. And I'm sure they'll come up with some solutions on that subject. The second thing is that the combination, I'm using 3D, and you know everybody, I'm using 3D heads-up display, but the combination of 3D heads-up display, the most important issue except seeing things in haze, the mechanical vision as they call it, is the one that you showed us today, beautifully done by Eckhart, is that you can superimpose things on the screen and you can do things combined that is lessen the danger of doing mistakes in the eye. And also, if you try to remove things from the eye, I mean, the first impression of how the holes were closing was made from a Japanese guy in the Vail meeting in Colorado that we went there last year, that he says that I'm doing a surgical OCT and I found out that if the hole is not closing in 24 hours, the hole will never, almost will never close. So we know now that with surgical OCT that if you don't make the closure quickly in the same 24 hours, it's very difficult to close the hole, and we know which way to go. So this is the future. You're watching it, and thank you very much. If there are any more questions, I would like to hear them. Okay. You were, absolutely.